Good afternoon. I'm Michelle Bianco, and I would like to welcome all of you to Accelero Health Partners Quality Collaborative. We wanted to convene a group who focuses on a daily basis to provide quality care to the musculoskeletal patient population. The value of this focused audience is to have the ability to leverage the success and challenges of our hospital partner network. The goal of this webinar is to share data on complications seen in the total joint replacement, spine, and hip fracture patient populations. We will also discuss the impact of comorbid conditions on complications. More specifically, we will dive into respiratory complications, which significantly impact the outcome of this patient population. After the data is shared to establish a foundation for discussion, we will invite all of you to participate in an interactive discussion. We will work to direct the discussion to minimize multiple people speaking at once. In the next few days, we will also share the presentation slides with the registrants in order to minimize your note-taking today. During the interactive session, these instructions will be used and shared again at the end. Because you are all in mute mode, please raise your hand using the feature outlined for us to call on you. You may use the chat session to ask a question if you prefer, and that is on the bottom right. Next, I would like to introduce Jenna Desormier, who will share powerful data to demonstrate the need for quality improvement in the musculoskeletal patient population.
Thanks, Michelle. As Michelle said, we will be spending a lot of the time today talking about complications, how to prevent and improve our complication rate, and then also asking you all to share best practices that you do, as well as working with others to share that information. But first, we want to give a little bit of background before we get to that. And I think everyone on the phone has heard the word value a lot in reference to healthcare recently. And it's not just value for value's sake, but value at a very low cost. Well, in order to make that happen, we have to understand what is value in healthcare. These are three definitions that we've seen recently trying to define what value in healthcare is. And you can see they're very different, and they come from people in healthcare. The two things that we do see that they all have in common, though, is outcomes and cost. And we all know that complications can negatively affect the patient's outcome and can also incur a lot of cost to the system as well as to the patient. So before we get into the clinical outcomes piece, what we want to do is start and set a baseline. So this information is from our OrthoVal database, and these are our joint replacement complication rate percentile rankings. So if your program falls around 4% complication rate for joint replacement, you're at about our 90th percentile. If you're at around 10%, you're at our 25th percentile. And you can see the distance between the two isn't that great. When we do look at hip fracture, though, that distance does increase a little bit. And this is because of the complexity and the difficulty of taking care of hip fracture patients. You also see that the start, the 90th percentile, is much higher than what we see in joint replacement, again, because these hip fracture patients are more complex. When we look at spine surgery, you can see it falls about in the middle, because spine surgery is more difficult and tends to take longer than a joint replacement patient. But unlike hip fracture, you do have the chance to optimize the patient. So if you're around 6% complication rate, you're at around our 90th percentile. 16%, you're at our 25th percentile. So if our goal really is to decrease complications so that we can increase value to the system, we need to know what leads to these complications. So what do patients look like that are coming in the door? So this information is also from our OrthoVal database. When we collect information from our partner hospitals, we ask for a clinical outcome data request. In that clinical outcomes data request, we ask for all secondary diagnosis codes. And we also ask for the POA indicator so that we can understand what was present on admit and what happened to the patient while they were in the hospital. These are all comorbidities that were present on admission for patients. And these are all of the patients in our database that either had spine surgery, major joint replacement surgery, or had a fracture repaired in the hospital. If we look at 3 very common comorbidities that we see in the literature and during discussions about patients, we can see what their general disposition is. So for example, hypertension. For spine surgery, around 50% of the patients have hypertension. Major joint replacement a little bit higher at 46%, fracture care a little bit lower at 42%. So this gives us that baseline. This is what, in general, patients have. For diabetes, we're looking anywhere from around 12% up to around 16%. For obesity, we're going to combine obesity and morbid obesity. So we're looking anywhere from around 9% for fracture care up to around 22%, for major joint replacement. And this is important information so that you can compare and contrast your own data too. Because what you can do is look and see how you do compare. If, for example, you have your information that you're looking at in orthoval and your diabetes percentage is around 2% for major joint replacement, you can ask yourself, does this feel right? Is this okay? If it's accurate, then that's one less comorbidity that you have to worry about for your patient. If it doesn't feel right, if you go back into your chart and look at information and realize, ooh, I think this may be wrong, we have a much higher percentage, then the problem may lie before the patient gets into the hospital, and we may need to do a better job of accurately documenting the risk factors. Now, there are also nationwide databases. This is a question that we do get often from our partner hospitals. How do we compare nationwide? There's the HCUP database or the NIS database that has over 7 million inpatient stays in it. So you can look at the information and compare yourself to that database. You can also use the NISQIP database. We would just stress that you know what the patient population is that you're comparing to. You can also look to the literature. So there are quite a few research articles that have been done to look at what are the risks prior to surgery for patients staying in the hospital longer, for being readmitted, for having complications. So that's also another area where you can go and look for information, similarly to this article about spine surgery. Now, even if you don't know the specific comorbidities or risk factors, you can go on simply the number of risk factors. This is a research article that looked at the number of risk factors and its effect on length of stay for total joint replacement patients. So along the bottom, you'll see the number of comorbidities. Along the y-axis, you'll see the length of stay. So for a patient who has 0 comorbidities, they stay a little over 2.5 days. For a patient who has 3 comorbidities, they're increasing their length of stay in the hospital to around 3 days. So just simply that increasing number of comorbidities, regardless of what it is, increases the risk that they're going to stay longer in the hospital. And that phenomenon is found in hip fracture as well. 0 comorbidities, they stay around 5 days. You go up to 5 comorbidities, and they're up to 6 or 7 days. So we know that simply looking at the number of risk factors can help us, and then also looking at specific comorbidities can help us assess risk prior to admission. So what are the specific complications that we're looking for? This information comes out of our orthoval database. What you're looking at here is the different complication grouping rates. So this isn't a distribution. You won't add up all of the numbers in the surgical spine column and equal 100%. What you'll find is the complication rate for each one of these product lines. So for instance, if we look at respiratory complications and look under surgical spine, you'll find 2.6%. That means there's a 2.6% respiratory complication rate for surgical spine patients. It's 8.4% for hip fracture and 0.9% for total joints. So respiratory complications are a consistent issue across all of our product lines. So what we want to do next is see if these patients look different. When we looked earlier at the general population, do those numbers looked different if we looked only at patients who had a respiratory complication. So if we look back at hypertension, we're similar. A little bit higher in joint, or actually a little bit lower in total joint replacement, a little bit higher in inpatient spine, but not enough for us to think that hypertension has any kind of risk associated with it for respiratory complications. If we look at diabetes, a little bit of a difference again, more so for total joint replacement and inpatient spine, so that may be something that you and your hospital partners may want to look at as a possible risk for respiratory complications. If we look back to morbid obesity and obesity, we see a much bigger jump in inpatient spine and total joint replacement. So this would be a key factor in respiratory complications in the hospital. So what are your hospitals doing to mitigate that risk prior to the patient coming in for surgery? We also wanted to look at a couple other comorbidities, more cardiopulmonary in nature. So you'll see congestive heart failure. This shows up on the list for the first time. When we looked earlier, it didn't even show up. It wasn't even one of our top risk factors. But when we decrease the patient population that we're looking at and look strictly at respiratory complications, that shows up on our list. So that's definitely something that your hospital partners should be looking at to mitigate risk for patients who have respiratory complications in the hospital. Also, the same goes for chronic airway obstruction. Obstructive sleep apnea, it's about the same for hip fracture, but we're seeing a large jump for inpatient spine and total joint. We're seeing at least a 10 percentage point jump from the general population to those patients who experience respiratory complications. So that means 25% of your patients who have respiratory complications have obstructive sleep apnea, 1 in 4. So if you're not doing something to mitigate that risk, you're missing an opportunity to make an impact. And what can you impact? So length of stay is definitely one. When we look at our entire database within OrthoVal, you will see what we're looking at here is the difference between without complications and with respiratory complications. So for surgical spine, the average length of stay for a patient who does not experience any complications in the hospital is 2.64 days. For a patient who does have a respiratory complication, they're staying on average 10.65 days. So that's an increase of 8 days. That is not the definition of value in healthcare. That's adding to cost, and it's adding to complications for that patient. And the same goes for hip fracture and joint replacement. We see that same trend in variable cost. Patients with respiratory complications have a much higher cost to the system than patients without. And then lastly, an impact to discharge to home, which more hospitals are concerned with these days because they're involved with more bundled payment projects. But if we look at joint replacement, you can see that on average, patients without complications go home 80% of the time. If they have a respiratory complication, they only go home 36% of the time, which is a huge change in the plan of care for these patients. So now that we've given you a little bit of background on these patients, what I'd like to do is switch over to my colleague, Michelle Bianco, to talk a little bit about his strategies for mitigating that risk before and after the patient hits the hospital.
Thank you, Jenna, for that wealth of information. Now that Jenna has demonstrated the impact of respiratory complications on length of stay, cost, and discharge, how do you mitigate that risk? And we recommend using a two-pronged approach. First, begin with evaluating preoperative risk. Although the timing varies for the emergent versus elective patient population, the process remains the same. During the preoperative assessment, it is important to identify key comorbid conditions that increase the risk of respiratory complications. While we may see many organizations evaluate lung disease and heart failure, for example, we do find that obstructive sleep apnea is not routinely evaluated. And Jenna mentioned for the total joint replacement patient, that is 1 in 4. It is suggested that adding an obstructive sleep apnea screening tool, such as stop-bang, is beneficial. Of course, identifying it and initiating treatment are two different things. If you take the step to add the assessment, you should also take the step to implement a process for specialty evaluation and treatment. Some hospitals have added this process at the point of surgical decision-making and scheduling in order to allow enough time for intervention. So that means it may occur at the physician's office. For those already diagnosed with obstructive sleep apnea, some anesthesiologists are requesting the patient demonstrate compliance with their device for a defined time period, for example, 4 weeks prior to surgical intervention, in advance of their surgery to reduce complications. It has been Accelero's experience that the preoperative process for many organizations is fragmented and inconsistent. It's a challenging process. Defining an approach that fits with your organization's need can create a seamless process for the patient while ensuring the patient is medically optimized prior to surgery. While there are several ways to accomplish this, critical to success is establishing a timeline for patients and what they should be, the timeline for which they should be seen prior to surgery, and have it by defined comorbid condition. Secondly is to define who medically evaluates the patient. As you see here, there are 3 different processes which we typically see as a preoperative opportunity. Do you need to have a specialist see all of your elective total hip and total knee arthroplasty patients? Or does the primary care physician own the process, yet follow the organization's guideline for preoperative processes? And that creates consistency. Establish who owns the communication and preparation of the chart to reduce surgical cancellation is critical to the process. And finally, ensure your preoperative education is valuable for the patients. It should position them not only for admission, but for a successful and timely discharge. While this structure is critical for the elective joint replacement and spine population, it needs to be fast-tracked for those patients who come in emergently, such as hip fracture. Implementing a defined process takes a multidisciplinary team with established written guidelines to prepare the patient for admission, regardless of which track you follow for preoperative strategies. Evaluating your data provides insight and also provides you with a direction for implementation of improvement strategies. During the data analysis, first determine your distribution of elective versus emergent cases. Many hospitals are surprised to find out that it is not really the emergent cases that are causing the complications, but rather it is the elective patient population driving the complication rate. Speaking specifically about respiratory complications, it is important to seek to understand your mix of specific types of complications, for example, respiratory failure versus aspiration pneumonia. This will help you identify specific processes for improvement based on the prevalent diagnosis. With the hip fracture patient population and the increased prevalence of patients being admitted from a skilled facility, it's important to evaluate the risk for pneumonia that is present on admission. This will limit your ability to get penalized, if you will, for a complication that really was an event that was the patient coming in with or present on admission. And next, it's important to identify the impact of pre-existing conditions on your patient population. Was there a correlation of those patients with obstructive sleep apnea on pneumonia, or those with COPD on respiratory failure, for example? It is also important to understand the impact of anesthesia on the outcome. Seek to understand if there is a trend with patients undergoing general anesthesia as compared to regional anesthesia for those patients with complications. This data analysis can direct your pre- and post-operative strategies. We have seen some hospitals provide an incentive spirometer preoperatively to those with pre-existing lung disease and instruct them in daily use prior to surgery, even giving them a calendar so they can document when they have utilized their incentive spirometer. For those patients with obstructive sleep apnea, instructing them in the value of preoperative compliance to their CPAP or BiPAP in advance of their elective surgery and increasing the use of pulse oximetry postoperatively has been seen to be valuable. In those hospitals who have identified a trend with a hip fracture patient, pain management approach on respiratory complications, engaging a geriatrician to support the development of a geriatric pain management protocol, is helpful. Accelero has seen value in utilizing chart audit and risk reduction tools to support process improvement. Using standardized tools that are customized to your patient population are valuable. On the right of your screen is an example of a pneumonia chart audit tool that looks at critical elements of the preoperative, intraoperative, and postoperative process. The document on the left is an example of a risk reduction checklist template that Accelero has used at many hospitals. Hospitals are utilizing this tool in a manner similar to fall risk. It identifies the population at risk and provides strategies for interventions that have been agreed upon by the hospitalist and the surgeon. Reducing complication requires dedication to continued process improvement. Having the data available is key. Bumping your data against comparative information will help you identify the criticality of the issue, as Jenna shared with you prior to our discussion. We know that documentation drives the coding of complications. And while we have seen the opportunity to improve documentation to more accurately reflect the care provided in some complications, we have found it very rare that documentation is the primary issue with respiratory complications. We have seen the vast majority of these coded complications to be true complications. As with any process improvement approach, be careful not to introduce too many changes at once. It will be difficult to deduct which strategies are the primary focus of the resulting improvements. We hope you have found the data and strategies for improvement of respiratory complications valuable. As we open for discussion, please remember to use these instructions. Raising your hand will allow us to unmute your line to initiate dialogue. Please raise your hand if you have a question related to the information that we have shared so we can open this interactive discussion. It appears as if there's a question from Shelley. Go ahead, Shelley.
Hi, I do have a question on your OSA screening. We're struggling with that at our hospital, and I assume that it's the same nationwide, that when we screen, we don't have enough time then to put a process in place preoperatively. So it seems to be an ongoing problem. You mentioned developing a program or a protocol for screening and then acting on the results. Do you have anything formal in place that you would share with the group?
Sure. I think those who have been very successful have identified and implemented a stop-bang procedure, for example, as an OSA screening tool, and implemented it at the physician's office. So when they have decided to have surgery and then subsequently scheduling them for their actual date, they are using that screening tool. And it may not be by the surgeon, but maybe by the nurse or PA that works in the office. Those patients who test positive on that stop bang and are identified at risk are then stratified to the next step. And that next step may be recommending that they go back to their primary care physician or directly referring them to the process for a sleep study in your existing facility. So those are things that we have seen to be valuable in our experience. I'd like to open it up to somebody else within the group if you can communicate what you have seen to be successful. Please raise your hand now. Well, Shelley, like you said, it is a really challenging process. What we can say is that many hospitals are just starting with a process to identify the risk. We do know that Joint Commission is looking for that during disease-specific care certification processes. So it is something that is being evaluated, I would say, during the certification process specifically. I would encourage you to move up the timeline of a stop bang or whatever other tool your organization uses to identify the risk. And one of the first places to check is within your existing organization for at the sleep study department. They typically are using a tool. You might as well use the same process for this patient population who, as Jenna identified, is at risk. Okay, any other questions? Please raise your hand. I don't see anybody else raising their hand. Jenna, as we've talked earlier, that preoperative process is really a challenge to organize and create strategies to risk stratify the patient population. That said, we know it's very important to reduce complications. Can you talk about your experience in implementing this approach with hospitals?
Absolutely, Michelle. I'm going to go into a little bit more depth of what Michelle was talking about as far as patient optimization and risk stratification. We really see it fall into 4 buckets, that first one being timing. So basically is, when do you need stuff to happen? And the best way to do that is really to work backwards. On the day of surgery when the patient's there, what information do you need? On the day before surgery, what information do you need? What decisions need to have been made? What information is critical to make sure that things go off without a hitch? And when you're thinking about that timing, when you're thinking about what happens day of, what do we need 2 days, 2 weeks before surgery, it really is built around how much time do you really need to optimize that patient? What's best for the patient, and what's the most efficient way for all of the providers and the staff to be used within that time frame. The second piece, or the second bucket that falls into, is the process. So you've got the timing, but how does the process work in around that? And Michelle talked a little bit about that, those possible 3 options. Is it a preoperative clinic, so that as soon as the surgery is scheduled, that patient goes to the pre-op clinic, they get the H&P, they get any patient optimization, any education done. It's all out of one clinic. Or if that doesn't work for your system, if it needs to be that the primary care physicians still own this process, then they still own it. All the patients go to their primary care physician to get evaluated before surgery. Or it might be a hybrid between the two, where the high-risk patients go to a preoperative clinic and the low-risk patients go to their primary care physician for evaluation. We've seen all 3 of those processes work really well, and they can work really well because you have a defined process of bucket 3 of the clinical information that you're going to gather. What do you need each one of those different processes to look for? What are the providers looking for to identify as a high-risk patient? And generally that comes from a meeting of the minds. Anesthesia, surgeons, hospitalists, primary care physicians come together and decide this is the information that we need to gather that we think would have an effect on complications after surgery, readmissions, problems in surgery. So this is the information that we want to gather and then stratify as far as high risk, moderate risk, low risk for these patients. And then that 4th bucket is what you do with that information. What happens? What is the plan for the patient? If they have diabetes and it's uncontrolled, what are you going to do to optimize that patient before surgery? What's going to happen during surgery and then after, once they're up on the unit? It should look different. If that patient does have diabetes, but they're at low risk because they're controlled and have been controlled for years, maybe nothing happens before, but day of surgery may look a little different, and the time up on the unit may look a little different, just as to look out for things and trying to get ahead of it. So it really is this culmination of these 4 big buckets into this process, which is really timing, process, clinical information gathering, and then that plan for the patient.
Okay, we'll open it up to any additional questions that the audience might have. Please raise your hand if you have not only a question, but if you can share some of your experiences on implementing risk reduction strategies that have reduced the respiratory complications in your patient population. Carrie?
Hi, can you hear me?
Go ahead. We can hear you now. Go ahead.
Okay, so I actually don't have an experience to share, but I did have a question, a follow-up question to the previous comment. So how do you address the issue of a surgeon really booking a case 1 week out from day of surgery where you don't have a 30-day lead time, you don't even have a 2-week lead time?
As we look to implement these strategies, it is key to have effective communication as to the timing of the process. So when we have worked with hospitals to implement this process, it is really making sure that we get everybody in the same mindset of what we should do to create a process. So by each comorbid condition, we look to have not only lab values or diagnostics that are required for that position, as well as the timing. So as it relates to obstructive sleep apnea, it's helpful to have a 4-week time out for surgery. Now, for those surgeons who are non-compliant or processes that aren't always people aren't always compliant to the process, I'll say, it is important that from a post-operative perspective, you make sure that if you identify that risk during their course of care, you quickly ensure that you have some of those risk reduction strategies put in place. So, for example, for the patient who comes in that maybe post-operative you see some breathing challenges, we have seen increased respiratory care, as well as making sure you have pulse oximetry on for that patient within the first 24 to 48 hours, so that you can identify if a patient is really challenged by that. Of course, having aggressive mobility is certainly helpful in those patients with lung disease or coming in with post-operative challenges. I hope that's helpful. I see that Becky Cooley also has raised her hand. Please go ahead, Becky. Becky, can you ask your question?
No, I was going to share an experience we had with, we have almost completely eliminated respiratory complications. We used the stop bang protocol, and we implemented it in PAT. We have an internal medicine physician who sees all of our total knees and total hips preoperatively. They come to PAT a minimum of 3 weeks before surgery, and we haven't had any problems with physicians trying to send them in a shorter time. We have a physician-led orthopedic steering committee that has looked at all the data and says that they must come a minimum of 3 weeks before, and so this is followed by all the physicians, and our internal medicine does all the screening and then refers them on if they fall out in the stop bang.
Becky, that was really helpful. Can you talk more specifically as to how you created that group and the time it took you to implement that process? I know that we would like to have it implemented overnight, but typically that takes some time.
It did take some time. We actually began working on total knees 3 years ago. We began with a journal club for the physicians, and we did extensive research through our one of the departments here at the hospital helped us with the research, and they did a journal club and came together, and then we got a multidisciplinary team that had people from the OR, from the orthopedic unit, from physical therapy, from home health, all came together, and we came up with order sets, and we came up with outlining exactly what procedure the patients would go through. We actually, each person on the committee actually shadowed a total knee patient. We went to their doctor's appointments with them. We shadowed them through PAT. We went to the holding area with them. We went into recovery with them. I actually went to their house when my patient had therapy from home health, and we took all of this information and looked at it and found what was best practice and compared it to what we were actually doing and came up with all of this. And we do have an internal medicine physician, and she sees high-risk patients in PAT, but she also sees every hip and every knee. So, and our hospital does use stop bang. That was anesthesia began that, and we do the pre-op classes, and we teach IS in the pre-op classes. We also, as part of our order sets, we get them up day of surgery. So it's been a long process, but it has we've had great results. Let's see, this year we've done 229 elective knees, and we've had no respiratory complications.
Becky, that information was so helpful, and I appreciate you taking the time to explain your in-depth process. I think some of the key points that I get from Becky's strategy is that it did take a multidisciplinary team. They looked at national data as well as their own information, and not only data, but process review. So they were able to look at the full process in which their patient population proceeded through the care elements and utilize that information to drive change. It certainly takes a lot of dedication for a team like that to get together, but based on the results that Becky just shared with us, it sounds like it was very effective. So congratulations to your team, Becky, for being able to execute such an outstanding strategy.
Thank you. And one of the things that has it has kept progressing, we had a new surgeon added this year who was an experienced surgeon, had done total joints at another hospital. And when he came here, we immediately met with him and talked to him about this is how we do it, this is what we do. And he came into our, we told him that he would be getting a report card every quarter like our physicians do, and he immediately came over. When he saw how much better our numbers were than his numbers, he immediately came over to our new process. So I think it's more than just, there's a lot of sustainment work to it. We do meet with the physicians quarterly and give them each an individual report card on their outcomes.
That's fantastic, Becky. So not only have you had the ability to impact the care processes within your organization, but demonstrate that to a new surgeon who has interest in applying those strategies. Can't get better than that. That's perfect. Thanks again for sharing your story, Becky. Anybody else have a strategy to share with the team? Because I think that's where the effectiveness of this group will lie, is in the sharing of best practice. I'd open it up to somebody else to raise their hand. Okay. I don't believe anybody else has any additional comments. What I would like to do is thank all of you who have attended this conference today. Our intent is to have another one and again focus on specific strategies for complication reduction. We hope that you found not only the data that was shared, the processes that were shared, but the level of communications with information that has been shared here today with the group valuable. The more often we do this, hopefully the less timid our team will be to communicate some of their challenges as well as strategies. It will only make all of us on the phone better and the resulting care for our patients improved. So thank you so much for attending. You can look forward to receiving a PDF of this slide deck so that you can use it as reference material in the near future. Thanks again, and I hope you have a great day.